Okay, great. Everyone can hear me? Wonderful. Welcome, everybody. My name's Daryl Abrams. I'm not Eddie Fan, if you couldn't tell. I'm filling in for Eddie as moderator for this session. Okay, excellent. So I'd like to first start by welcoming up Ethan Sanford on the association between disrupted cerebral autoregulation and radiographic neurologic injury for children on ECMO, a pilot study. I think for now we'll try to save questions for the end just to make sure we get through all of the abstracts and oral presentations. And looking forward to a nice talk. Thank you.
This clicker will work somewhere. Hello, everyone. Thanks for coming. My name's Ethan. I'm an assistant professor of pediatric anesthesia and pediatric critical care at UT Southwestern in Dallas. I'm pleased to present our work on cerebral autoregulation and neurologic outcomes for children on ECMO. So this audience knows that severe neurologic injuries is common and promotes a poor outcome for children on ECMO. Estimations are about 10 to 15%, at least neurologic complications in the registry. And that probably underestimates because children who have imaging after surviving ECMO have about 50 to 60% documented injuries on head imaging, a third of which are severe. Current modalities for monitoring neurologic function on ECMO are limited to sparse time point measurements. They often require expert operators to assess them, such as EEG and TCDs. And then NIRS, while maybe associated with poor outcomes, is not specific for neurologic injury. And therefore, all of these modalities really don't do a good job of predicting injury rather than diagnosing injury. And that's why our group is interested in looking at diffuse correlation spectroscopy, which is very similar to NIRS in that it has a light source and a detector. At the detector, it uses the frequency of scatter as well as the amplitude of scatter to estimate first a baseline blood flow, and then as there are changes in blood flow can tell you the amount of change, either positive or negative. When you correlate that with blood pressure, that gives you an estimation of cerebral blood flow, assuming you've applied the DCS to the head. So increased DCSX is what we've termed it, is essentially correlation between blood flow and blood pressure, and that is thought to intone disrupted cerebral autoregulation, which we think is bad. So we have conducted an initial prospective observational cohort study on children who were cannulated to ECMO in either the pediatric or cardiac ICUs at our center. The primary exposure being DCSX and the primary outcome being radiographic neurologic injury as scored by a blinded neuroradiologist, higher scores being worse injury than lower scores. So of the 33 children enrolled, I learned through this study that doing research in ECMO is difficult, as we had 16 patients who were ultimately available for analysis. We did have a feasibility arm. We had some issues with practitioners not wanting us in the room to measure during critical times. And then 7 of the children did not have an eligible head CT or MRI for which we could make the neurologic scoring assessment. So this is the study population. You see the age was about 1.5 years. We did have pretty good discrimination in neurologic injury between 6 of the patients and the rest of the cohort. You can see there the rest of the demographic and clinical factors. We had a mix of VV and VA, which is a hot topic among some, but I won't go into that very much right now. So the primary outcome of assessed by linear regression, we found that there was an association, a positive association between elevated neuroinjury scores and elevated DCSX, which is consistent with the initial hypothesis that time in cerebral dysregulation is associated with radiographic neurologic injury. Another way of looking at that is that scores of 10 or more in the past have been, neuroinjury scores of 10 or more have been associated with worsened functional outcomes. And so dichotomizing based on that score, we found that the high neuroinjury score group had higher median DCSX values. There are many limitations to this study, the initial being we're only measuring for 1 to 3 hours once a day while on ECMO. So these sparse time measurements almost certainly preclude us from measuring at the time of neurologic injury. Additionally, patients who did not survive to decannulation may not have had appropriate head imaging, so we might have some selection bias in our patient population. And we had modest numbers of patients. So this pilot study has fueled us to proceed with a R01-funded study that's going to be monitoring DCSX for the first 48 hours of ECMO. And for study participants, we're going to get a head CT at 48 to 72 hours to assess for the primary outcome of radiographic neurologic injury. We'll look at an assortment of other secondary outcomes, and these are the next steps for us. Thanks so much for your time, and I'd like to thank Dr. Rahman, who's my mentor for the project.
Wonderful. Thank you very much, Ethan. I think we'll move on to the next talk and then leave time at the end for questions. Okay, so now the next talk is by Michael Collenmauer on platelet function in pediatric ECMO patients. Thank you very much.
Good afternoon, everyone. My name is Colin Maurer, and I'm a pediatric critical care physician at Cook Children's Medical Center in Fort Worth, Texas. Today, I'm going to be talking to you about my fellowship project out of UT Southwestern, also with Dr. Rahman, evaluating platelet function in pediatric ECMO patients. This project was obviously supported by an ELSO grant for $10,000. I have no other financial disclosures. As we all know, the high rates of morbidity and mortality experienced by patients undergoing ECMO are often secondary to catastrophic clotting and/or bleeding complications, including intracranial hemorrhage and surgical site bleeding, examples of which are shown here. Institution-specific protocols standardizing transfusion management are in place to attempt to mitigate bleeding complications. Thrombocytopenia is widely considered a major determinant of bleeding risk, resulting in platelet transfusions at various platelet counts regardless of clinical signs of bleeding. However, platelet function also likely contributes significantly to bleeding risk. This has been demonstrated in diseases such as immune thrombocytopenia, or ITP, where some patients exhibit minimal bleeding at lower platelet counts, while others suffer significant hemorrhages at higher platelet counts. A systematic review in Australia looked at 3 articles on platelet function in pediatric ECMO patients. Results showed reduced platelet function in patients after going on ECMO compared to before initiation of ECMO, and in non-survivors when compared to survivors. This suggests that not only do patients undergoing ECMO develop acquired platelet dysfunction, but also that platelet dysfunction has a negative impact on mortality. Overall, the authors concluded that this review demonstrated the extremely limited literature available on platelet function in pediatric ECMO patients. So as you can see, there's a significant knowledge gap in what is known regarding platelet dysfunction in our ECMO patients and whether we are transfusing appropriately in this patient population. The hypotheses for our study were that patients undergoing ECMO would have platelet dysfunction and that patients undergoing ECMO with platelet dysfunction would have increased bleeding and need for blood product transfusions. We evaluated this by enrolling 9 patients. It's not working. There we go. We evaluated this by enrolling 9 patients, ages 0 to 18 years old, undergoing ECMO, admitted to Children's Medical Center in Dallas, Texas. This group included patients undergoing both VV and VA ECMO. We collected blood samples on patients at least 24 hours after initiation of ECMO to undergo platelet flow cytometry analysis and extracted additional data from the electronic health record. Samples underwent flow cytometry on the Fortessa flow cytometer. Each sample was divided into 3 runs, a run with no activator, a run activated by adenosine diphosphate, and a run activated by thrombin receptor activating peptide. Attempts were made to minimize pre-activation of samples and further platelet degradation by running the flow cytometry within 2 to 4 hours of collection and obtaining all samples from a free-flowing arterial line. The EHR data collected included ECMO circuit flow at the time of sample collection, coagulation and blood count laboratory results, incidence and type of bleeding complications, number and type of transfusions required, and morbidity and mortality, with the primary endpoint of the study being platelet dysfunction and secondary endpoints being increased bleeding and need for transfusions. The ages of the patients in the study range from 4 days to 16 years. The study was 44% female, with median weight being 7 kilos. 2 patients were cannulated for COVID respiratory failure, and 67% were on ECMO, VV ECMO configuration at the time of sample collection. When compared with healthy adult non-ECMO control samples, a majority of the patients had decreased expression of GPV1 and CD42B. The percentage expression of GPV1 and CD42B for patients 1 through 9 when compared to the healthy controls A and B are seen here. GP is a platelet surface marker involved in platelet activation and aggregation, while CD42B is a platelet surface marker that serves as a receptor for von Willebrand factor. So both obviously important in the clotting cascade. The expression of the other platelet markers we tested for were not significantly decreased. For the sake of time, I'll focus on the transfusion requirements and bleeding complications of only the 4 patients that showed the greatest decrease in expression of the 2 markers previously discussed. These patients did not experience significantly increased transfusion requirements, bleeding complications on post-ECMO MRI, or mortality when compared to the study population as a whole. However, the ability to compare transfusion requirements is somewhat skewed by individual provider practice that deviated from the preset transfusion thresholds in our ECMO protocol. The study is limited by its sample size, and the sample size was in part due to the rapid turnaround required from time of sample collection to analysis. And unfortunately, the laboratory we were working with experienced a high volume of staff turnover, which limited our ability to analyze samples. In summary, pediatric patients undergoing ECMO may have decreased or altered platelet function. However, this was not shown to be correlated with increased transfusion requirements or bleeding complications. Further studies are needed to elucidate this problem, and consideration should be given to not only treating the platelet number, but the patient and their bleeding complications. Again, thank you to Lakshmi and ELSO for all their help with this project.
Thank you very much. I believe next we have Elizabeth Harrop on caregiver perspectives on family-centered follow-up and priorities for families in pediatric recovery. Thank you.
Thank you. All right, I'm just going to get started. There we go. Okay, so as many of you know in this room, the neonatal and pediatric ECMO hospital survival rates range from between 42 to 73%, depending on the reason a child went on to ECMO in the first place, among other things. Importantly, children surviving greater than 3 months after ECMO have a high 10-year survival rate. But survivors are at increased risk of physical, cognitive, and emotional health impairments. And for this reason and others, ELSO recommends structured health and neurodevelopmental follow-up post-discharge. However, evidence reporting families' priorities in post-ECMO follow-up care is limited. That being said, there was actually a nice study published around the time that we were developing our own research ideas out of the UK that addresses this very topic, so I do want to give them credit. So our study aim was to elicit caregiver perspectives regarding vital components of and challenges to participating in ECMO follow-up care. This was an electronic survey that we sent out to consented caregivers of pediatric ECMO survivors who are less than 18 years of age. And these survivors were admitted either to the cardiac ICU, pediatric ICU, or neonatal ICU at the UPMC Children's Hospital of Pittsburgh between the years of 2015 to 2020. The survey itself consisted of 25 questions, most of them being multiple choice, and then there were 3 open-ended questions. And you can see here what the survey items assess, but I'm going to move on to the results. Methods were straightforward, and we just used basic descriptive statistics. So there were a total of 171 patients who were cannulated onto ECMO between 2015 and 2020. There were some patients taken out of the running for the reasons listed there on the right. Ultimately, we reached out to 121 families. We were able to reach about 94 by phone, and of those, 50 of the families consented and at least started the survey. In terms of parent demographics, so it was a homogeneous sample in some sense because the vast majority were mothers and were white, but their socioeconomic status was more variable. And then in terms of patient demographics, it was a fairly young population, so the median age at time of ECMO was 101 days, or a little over 3 months. The majority were required ECMO for cardiac reasons. And then the median duration of ECMO was 92 hours, or a little under 4 days. And then the median hospital length of stay was about a month and a half. So we asked parents to evaluate from their perspective, their child's overall health, both before and after ECMO. And interestingly, according to this figure here, they actually, there was a trend in improved health after ECMO compared to before. However, they did report increased health challenges after ECMO, which isn't surprising, but a little bit different compared to the previous slide, as compared to before, in multiple domains, functional and neurocognitive domains. And also, not entirely surprisingly, more children required both home care or home nursing care services, as well as learning support for school-aged children after ECMO. I wanted to put this table up here just to show that the burden of visits that a child and family requires after being on ECMO is significant and certainly goes up after as compared to before. We asked parents how easy or difficult it was for them to have their child attend both in-person and virtual visits with their healthcare professionals. And close to 70% said that it was very easy or moderately easy to attend in-person or virtual appointments. But there were about 34% of families said that the distance between their home and the healthcare facility proved to be a barrier, as well as both the number of appointments they had to attend in person, as well as being able to get a timely appointment. And then we asked if there was such a clinic that existed where it would be a multidisciplinary setup and the family and child could come and see multiple providers at the same time, how interested would families be in this type of healthcare model? And about 2/3 said that they, for in-person visits, said that they would be either extremely likely or somewhat likely to engage in this type of healthcare model, and then even more, up to a little over 75% or 3/4 of the families had an interest in a virtual model. So I just wanted to end with my last couple of slides, and this one being some direct quotes from parents from open-ended questions, which were illuminating. So in terms of the parents' psychosocial impact, you can see here one parent said that their biggest, or his or her biggest challenge was anxiety and mental health during the time and after their child was on ECMO, and that they were afraid to fall asleep. There was another parent who said that navigating life with a child who has limited mobility on top of battling developmental delays and significant medical conditions was difficult on a daily basis. In terms of the psychosocial impact on children who have been on ECMO, one parent commented that at the time that her child was on ECMO, and he was the child was 4 years old at the time, she felt like it was hardest on him psychologically, since he had some understanding of what was going on, but not entirely, and didn't know how to cope. And then we did ask about the impact on sibling relationships. And I have a couple of quotes up here. There were multiple comments about siblings of children who had been on ECMO struggling, feelings of sadness, frustration, and anger. School went by in a daze, and then some separation anxiety for siblings. There were also some comments, I should say, I couldn't include everything here, but some comments about how there was kind of positive growth between sibling relationships as well after a child was on ECMO. And then importantly, families brought up several types of supports that they felt could be improved going forward and for other families in the future. So one thing that came up several times was peer support and finding a way to connect families who had been in a similar situation with those going through a situation in the hospital. Certainly helping to manage with the many appointments after hospital discharge was another thing that was mentioned pretty frequently. And then providing adequate parent education or caregiver education regarding what life may look like after a child has been on ECMO. So in conclusion, parents of pediatric ECMO survivors identified specific unmet needs, including parent and improving upon parent and child emotional support, improving upon the organized neurodevelopmental longitudinal support, and then certainly help with coordination of care post-hospital discharge. And ultimately, there is an urgent need to establish a more structured, multidisciplinary ECMO follow-up model of care. And certainly, in doing that, families should be included. Thank you very much.
Thank you very much. Okay, the next talk is on improving neurological outcomes after respiratory arrest using a porcine eCPR model by Dr. Garcia. Welcome.
Yes, thank you for the opportunity to present our research. I'm a pediatric surgeon at Johns Hopkins Children's Center. I have no financial disclosures. So as we all know, the use of ECMO in children has increased fourfold over the last decade. eCPR has been shown to improve survival after an in-hospital cardiac arrest from 27 to 40% in children. Unfortunately, neurologic outcomes remain high after eCPR, with about 7% of children sustaining brain death after eCPR, and those that have CNS infarction or hemorrhage having worse survival. In terms of oxygen, infants with congenital heart disease who were placed on ECMO, previous studies have shown that hyperoxia within the first 48 hours was an independent risk factor for mortality. In children, hyperoxia during ECMO support is common and independently associated with mortality. In adults who require eCPR, even moderate amounts of hyperoxia was associated with increased mortality compared to normoxia. So there are no guidelines that exist for how to properly correct hypoxia in patients following eCPR. So we hypothesized that hyperoxia following a respiratory arrest would lead to a reproducible neurologic pattern of injury, and then brain biomarkers could be used to detect injury. For our study, we used 4-week-old domestic swine. These were mechanically ventilated after anesthesia. The femoral artery and veins were cannulated for hemodynamic monitoring. We placed a Lycox monitor in the posterior brain parenchyma to measure brain tissue oxygenation. We caused a respiratory arrest by occluding the endotracheal tube for 7 minutes, and we used an ultrasound to confirm cardiac arrest. eCPR was performed for 20 minutes. We cannulated the piglet similar to a neonate by using 8 French cannulas in the neck. VA ECMO was initiated at 100 cc's per kilo per minute, and we ran ECMO for 4 hours. We obtained biomarkers throughout the study, and we performed postmortem histology. We had 4 arms in our study. We had an arrest arm where we included piglets who had normoxia following the arrest, starting at 21% FiO2 and titrating up to target a oxygen saturation of 92 to 98%. And then in our control arm, these piglets did not have an arrest, but were placed on ECMO and also had the same oxygen configuration. This is an example of our lab setup with the Lycox monitor there on the left and the ECMO cannulas in the right neck. We use the standard ECMO roller head pump with a Medos halide oxygenator. And we maintained PaCO2s in the normal 35 to 45 range. When we looked at our brain tissue oxygenation using the Lycox monitor, we found that the patients, the piglets who had hyperoxia in the blue and the gray had higher levels of tissue oxygenation compared to the normoxic piglets. We then looked at serum lactate at the end of the experiment to see if there was a difference in an organ injury amongst the piglets, and they were all within the same range. And then we focused on the histology. So we had a blinded examination of the brain stems of these piglets, and we looked for viable, injured, and ischemic necrotic neurons. In this figure, the one further on the right is our control piglets with hyperoxia, and you can see that they had the highest number of viable cells, and in the green box is the piglets who underwent eCPR with hyperoxia, and they had the least viable cells. And looking at it in an inverted way, so these are looking at injured cells. The green box on the left is the eCPR with hyperoxia, and they had significantly higher levels of brain-injured cells compared to the control hyperoxia. And again, looking at ischemic necrotic cells, the control piglets had no ischemic necrotic cells as opposed to those who underwent hyperoxia. And in the orange, you can see the normoxia. And this is just a picture of the histology with the control on the left with healthy neurons and the eCPR hyperoxia with the necrotic neurons. So in conclusion, we established a reproducible pediatric porcine model of eCPR following a hypoxic arrest. This model demonstrates differential injury to the basal ganglia following different strategies of hypoxia correction after an arrest. This model will be used to further study strategies to minimize reperfusion injury and mitigate neurologic injury. Our future steps, we are currently analyzing biomarkers. GFAP has been shown to correlate in piglets as well as in humans. In the future, we hope to titrate PCO2, as we know that that can also have an effect on perfusion to the brain. We also would like to use a fMRI that our collaborators have access to. And ultimately, if we could survive these piglets and not extend it beyond 4 hours, I think that'll be helpful to see clinically what neurologic outcome these piglets have. I'd like to thank my mentor, Mela Bembia, as well as ELSO for the grant support. Thank you.
I believe next we have Rachel Sundland, is that right? On improving neurological, does an educational video improve parental understanding of ECMO?
Okay. All right, so that was very exciting. So my name is Rachel Sundland. I'm a PGY3 general surgery resident, and I'm going to be presenting some ongoing findings from a project at the University of Chicago titled, Does an Educational Video Improve Parental Understanding of ECMO? Nope. Nope. Okay. So as we all know, ECMO is an incredibly complex, life-saving technology. The way we educate parents about this supportive intervention is typically through multiple discussions led by both intensive care unit doctors and surgeons, as well as sometimes through the provision of an educational pamphlet. Despite these conversations, the complexity of ECMO, including its risks and limitations, is difficult to comprehend. This is particularly true for stressed parents and guardians who are experiencing one of the worst times that a person can go through. Additionally, for the neonatal patients, the first time their parents may actually see them after birth is when they've already been placed onto ECMO, and the experience of walking into the unit, seeing their baby intubated with multiple lines and tubes and drains can be extremely disturbing for these parents. So, knowing that oftentimes when we talk to parents, the information we say is actually not really heard, what we wanted to do was to find a way to educate these parents on the critically important points regarding what ECMO is as a supportive measure of care, the risks that are inherent to being on ECMO, and the fact that these children will need close, long-term follow-up care because the risk of some type of neurodevelopmental injury is a real possibility. And finally, what we really wanted to do was to find a way to use animation to visually display the appearance of a child when connected to the ECMO circuit and all the other critical support devices, as well as the large number of people that will be at the bedside and be involved in the child's care so that the parents could be more prepared for what they will see and experience when they're walking into the unit and while their child is on ECMO. Oh, shit. Okay. So the primary objective for this study was to create an educational video that improved parental understanding of the procedures, support types, and complications associated with this complex medical technology, and to assess the effectiveness of this method as compared to our current practice. We also wanted to assess participants' subjective evaluation of their own understanding of the information that was provided. And we hypothesized that the educational video would improve knowledge about ECMO and increase participants' feelings of comfort with this knowledge as compared to listening to the audio alone or reading a pamphlet. So we designed a red cap survey to administer the ECMO knowledge pre and post test, which included 5 basic questions regarding what organs ECMO supports, how sick a patient is on ECMO, and the risks of ECMO, as well as the aftercare for ECMO. Participants were randomized to one of 3 educational arms, either listening to the audio, reading the pamphlet, or watching the video. The survey was then sent out to parents at a local Southside Chicago high school in order to recruit a larger number of participants who would be an accurate representation of our hospital's patient population. So very briefly, I just wanted to show a short clip. Oh no. I don't know if you can actually hear it. Nope. Okay, so what we have found thus far is that all participants, when provided with any form of education, will significantly improve on the test questions. However, the amount of improvement was not significantly different between the groups. And while there was no statistically significant difference in the subjective level of comfort with the knowledge, those who watched the video did have a higher average on our Likert scale than those who were in the other 2 arms of education. So the next step of this initial phase is really going to be to recruit more participants in order to find if there's a smaller difference between the 3 groups that's identifiable with more people. But I think that the reality of the situation is that if you give people a setting where they can sit down and read or listen to something, we won't find a statistically significant difference between the groups. But what I think is clinically significant is that we have parents who are illiterate. We have parents who cannot read. We also have parents who are not at our institution when their baby comes to us. And adding an educational video to our armamentarium will only allow us to better care for these patients and their parents. Thank you. Circus.
We baked an extra. This is why we baked an extra 20 minutes into the session. And lastly, we have Nicole Diaz, automated pupillometry for the prediction of neurological outcomes in children requiring ECMO. And after that, I'd like to invite, I think Dr. Maurer is the one, up to the podium for discussion and questions at the end. Thank you.
Hi, everyone. My name is Nicole Diaz, and I'm a third-year PICU fellow at UT Southwestern. The pupillary reflex is an important part of the neurologic exam. However, it is very subjective, with studies showing weak inter-rater reliability for both pupil size and pupil reactivity. The automated pupillometer is a handheld device that quantifies the pupil reactivity via the Neurologic Pupillary Index, or NPI. Values range from 0 to 5, with any score less than 3 indicating an abnormal pupillary response. We have been using this technology at UT Southwestern Children's Medical Center for the last 4 years or so, and it is now standard of care in our neurocritical care and trauma patients. There's not much published data on the benefits of pupillometry in critically ill patients. There is a paper that was published in Chest in 2020 that concluded that any NPI less than 3 in the first 24 to 72 hours after VA ECMO insertion in adult patients strongly predictive poor outcomes at 3 months after discharge. So we hypothesized that any NPI less than 3 in the first 72 hours after any ECMO insertion will be associated with poor or unfavorable short-term neurologic outcomes, which we have defined as PCPC of 4 to 6, a functional status scale of greater than or equal to 16, or a neuroimaging score of greater than or equal to 10. As Dr. Sanford discussed, the neuroimaging score looks at neuroimaging in ECMO patients, and it has been validated against adapt behavioral outcomes. And scores greater than or equal to 10 have been associated with poor outcomes. This would be a retrospective single-center study. We will include all pediatric patients in our institution that have undergone ECMO at both the PICU and the CVICU between August of 2020 and October of 2022 that have had an ECMO run longer than 24 hours and that have more than 1 pupillometry measurement done in the first 72 hours. Ideally, we'll be measuring this neurochecks every 6 hours with a pupillometer for the first 72 hours, and then at least twice daily for the rest of the run. And additional measurements is clinically indicated. So I'll present the data up until December 2021. In this time period, we've had 74 patients. 18 of these were excluded because they didn't have any pupillometry measurements, and a further 12 were excluded for the reasons listed on the slide, leaving us with 44 patients. As you can observe the baseline characteristics, there was no difference in age or gender or type of ECMO cannulation, but there was a statistically significant difference in indication for cannulation, with patients with an NPI less than 3 more likely to have a cardiac indication. Additionally, patients with lower NPIs had a shorter ICU length of stay and a shorter overall hospital length of stay. Now, looking at outcomes, these patients with NPIs, any NPI less than 3 in the first 72 hours were more likely to have unfavorable neuro outcomes, as I already described. Additionally, they were less likely to survive to decannulation and to hospital discharge. And here I have broken down the population into patients with unfavorable outcomes and patients with favorable outcomes. As you can see, patients had similar number of pupillometry checks during the 72-hour period, around 10. However, the percentage of measurements less than 3 was significantly different, with patients with an unfavorable outcome having about 15% of their measurements less than 3, compared with about 1% in the other. So moving forward, we'll continue to add patients to our study up until October 2022. And then we'll make a follow-up appointment with them, or follow-up at 6 to 12 months as a standard of care in our institution to follow up their functional and behavioral outcomes long-term. I would like to take the opportunity to thank ELSO for this financial support. Additionally, I would like to thank the nursing and physician staff at my institution and my mentors, Dr. Lakshmi Raman and Dr. Daryl Miles. Thank you.
Thank you all very much. First, congratulations to all the speakers on their grants. They clearly went to wonderful use. So congratulations on all the presentations, the fact that some of them are leading to R01s and other larger grants going forward. I'd like to open it up if there are any questions. Otherwise, I can start off.
Dr. Terria from Houston. I have a question for Dr. Kalimura. I may have missed. What kind of anticoagulant did you use? Heparin or bivalirudin?
Yes, all the patients that we had in our study were on heparin. Our institution does use heparin and bival, but all 9 patients that were included in the study were on heparin.
Okay, I think it is very interesting if you do the same study when you use a bivalirudin, because heparin activates platelets, as you know. And what's the time point did you take for those specimens?
Yes, so ideally they were collected approximately 24 hours after the initiation of the ECMO run. But as I mentioned, due to the fact that the sample had to be run within 2 to 4 hours after collection, that did limit us to daytime, weekday collections. And so the range of time was anywhere from 24 hours up to 72 hours.
Yeah, my question is, so is it a progressive or stays the same? I'm sure you got a specimen one time, but so it's so the ECMO run time is longer, maybe longer. So then the patient may lose the function more. So that may be interesting.
Yeah, absolutely a limitation of the study. In the patients we did have enrolled, there was no correlation or didn't appear that the patients that had their samples collected later in the run had decreased function compared to the patients who had it collected earlier in the run. But again, hard to tell with that small of a sample size.
Okay, thank you.
Hi, Joe Tona from Salt Lake City. I love the abstract sessions. It's like my favorite. So I have a couple of comments and questions. So Dr. Sanford, I had a question for you. So you're measuring the CT as the outcome at 48 hours after ECMO initiation and then getting the nurse during that intervening period. Do you think that that's, as I understand it, do you think that that is an adequate period of time? If presumably the injury is occurring at the moment of ECMO cannulation or sometime around there, do you think that 2 days is adequate delay? Or is there prolonged injury that's going on where you might not see a radiographic change on CT reflective of the injury that early?
Yeah, thank you for the question. It's sort of a balancing act, I think, of getting patient numbers as well as enough time for actual injuries to occur. So presumably, kids who don't survive 48 to 72 hours, those also present a challenge because they might have injuries along the way that we're not going to be able to document. Versus those who survive longer periods of time, is there a gap of time between that 48-hour to 72 and the having a neurologic injury that then we wouldn't capture with DCSX. So in an effort not to possibly miss those who had an injury earlier in their time course, but then wouldn't survive to a longer time period wherein we could take the measure, we had to sort of pick a number. There's limited data on when injuries occur on ECMO. It might happen before cannulas are ever put in. They might happen right when cannulas are put in. They might happen 14 days after cannulas are put in. So we do think that that will be a limitation of the study, but we hope that with the 48-hour to 72-hour time frame, we'll be able to capture the majority of patients who have those significant injuries that we're trying to prevent.
Thank you.
Hi there, Sandra Buttram from Phoenix Children's. First, I'd like to congratulate all of you. You're all doing amazing work, and this is exactly what we need for our field to learn more and get better at what we do. Dr. Garcia, I have a question specifically for you. On your box plots of your PBRO2 measurements, in your hyperoxia groups, it actually looked like some of your PBO2 measurements, whereas your box plot range was quite wide and down, in fact, into the 10 to 20 range, which, at least for traumatic brain injury, we think LICOX measurements, right, based on the pediatric TBI guidelines, the goal is greater than 10 and probably ideally greater than 20. So I completely agree that there's lots of data to that hyperoxia is bad for the brain, maybe equally as bad as hypoxia. But how do you interpret your LICOX measurements with the rest of your data?
Yeah, it's a good question. We obtained the LICOX and we tried to use it in our piglet model to see if it correlates the same as it would in a human. I'm not sure. I would expect it to be higher in the hyperoxia group, and we did see a little bit of that. We only had 2 piglets in each arm, just the limitation of the study, so I think that's what led to a lot of the variability. And there's also the learning curve. As we started using it early on, even though we sort of randomized which pigs we did in the order we did them, there may have been some variations with that. So I'm hoping with a larger cohort, maybe we won't see that variability.
My only other thought is, I have no idea what the cerebral vascular anatomy of a piglet is compared to a human, so it may be where you're placing your LICOX, right? Like, at least, right, ideally, if I could place it in a post-cardiac arrest patient that needed eCPR, right, I'd want it in deep gray matter, because that's where we see, right, the biggest hypoxic ischemic injury, so it just might be something to consider in the future.
Great, thank you.
Lakshmi?
Thank you all for the presentation. For Dr. Garcia, I had a question. I know you showed the LICOX data. Was there any correlation with the blood PaO2? Because, in ECMO patients, it's going to be very hard for us to get LICOX measurements. And did you try to correlate with blood PaO2 measurements so that we could stratify them and see? I completely agree, probably hyperoxia is not good, but would that be helpful was my question.
Yeah, it's a good question. We do have that data. We do have the pHs and the PaO2s for all these, but I haven't done the correlation yet to see if it correlates with the LICOX.
Yeah. And then Dr. Harrop, that was a great, I think the parental survey is a very good one. One of the thoughts I had was, did you try to see if there was a difference between cardiac and respiratory patients? Because I do think the cardiac population is a different group, and they may come up with already a high stress, and that was one question. And then the second was really a comment that I don't know if you had a chance to look at the ELSO guidelines about follow-up and this one, and I think it's so important for all of us as a community to really have some way of doing this follow-up. And I know it's very resource intense, and I think if we all join hands, I think that would be the best way to make this possible, to convince your hospital and potentially insurance companies that this has to be the standard of care, because it's not enough if we just put these patients on ECMO and forget about them, but there is a need for follow-up. Thank you.
Yeah, thank you for your comments. We did talk about trying to sort of see if there's any difference in experiences between the families who have had a child in the NICU, the PICU, or the cardiac ICU. Part of the issue is that the parents who, they're supposed to be, anonymous responses. So, and I'm also not sure we have quite a big enough sample size to figure that out, but we've definitely thought about it, so it's an important point. And then, yeah, as you mentioned, having this type of comprehensive, longitudinal, multidisciplinary follow-up is very resource intensive, but also incredibly important, and will also help us to better understand long-term outcomes for these patients and how we can better help them and their families. I think it'll be, different from institution to institution, but my hope is that it'll become more widespread around, pediatric institutions who provide ECMO services. So, thank you.
Along those lines, was the majority of this during COVID or pre, and did the emergence of telemedicine impact, or do you think it will going forward?
I do think at the time that the parents were answering the survey, it was impacted by an increase in virtual visits because of COVID. But the families who had children on ECMO, those children were in the hospital, at least for their primary ECMO run, between 2015 and 2020, so maybe towards the end.
But maybe going forward, that could be a way to, with the multidisciplinary kind of a follow-up.
Exactly. It could be kind of a hybrid approach, since the majority of families had an interest in a virtual visit, and that wouldn't work for all types of visits, but maybe at certain time intervals it would work.
Joe?
Yeah. Dr. Sundlin, I had your study was awesome. I love this idea because, so I'm an adult intensivist. I take care of a bunch of old people on ECMO. And so often we have family members who come in who look at their loved one, and we've just got everything. And it's really traumatic for them too. I'm sure not nearly as much as, it is for parents. But I wonder if you actually had photos of kids, obviously, sorry, like blocked, but like I loved the idea of the cartoon, but I almost wonder if it wasn't assaulting enough to like break them down before then they actually saw their kid. As a parent, like I would lose it, right? And so even maybe seeing a photo would be a little closer. Just a thought or question.
Yeah, so we thought about that. We definitely do have, photos of kids on ECMO. But the person that we were working with to create the video, I sent him the pictures so he could make the bear and do all the cute animation and things. And he was telling me that he was like traumatized by the photos and was having to repeatedly delete them anytime I would send him something.
Yeah.
So we were a little hesitant to add those photos for that reason. But I do think it's really important because especially as I was doing this project, I did my research with University of Chicago during COVID. And these parents were by themselves at bedside, seeing their baby on ECMO for the first time. And these mothers, especially in the NICU, like the emotion is just so overwhelming for them. So I think it is really important to sort of prep them. And maybe we do need to sort of, as you said, assault their senses with real photos, maybe just one. We can prep them with a bear and then assault them at the end.
Thank you. And then Dr. Garcia, one kind of a question comment. I've done a little pig work myself, and one of the things that we notice is, one, it's really hard to do CPR on a pig because of the pectus. And it's also hard to cannulate ECPR on anybody. And so one of the things we started doing was dissecting down and actually cannulating prior, and then just leaving it clamped and then starting the flow later, as opposed to doing it during. And I bring that up because I wonder if inherently, even if reviewers won't pick this up, you're inducing variability in the cannulation process during CPR in the subjects.
It's a great point. We did consider how difficult, with the variability of CPR, how difficult it is to cannulate. We did want to kind of correlate as best we can with the actual human, eCPR, we're cannulating during CPR. We start with our neck exposure and have our vessels exposed, and then arrest the pig, do CPR. So we try to standardize it to a certain extent. But you're right, the CPR does have variability.
I want to echo Joe's comment about having some gruesome pictures. In fact, one of the moms that I interviewed for a video, she said, when I walked into the room, there was this tubes of blood coming out of him. And I failed to think of it like that until that mom told me. And I think I just wonder if you could have like the mannequins that we use for simulation with tubing of artificial blood, which may not be a child and you're not violating HIPAA things, but something more. But that's great work. Yes.
Thank you. The sim is a good idea. That's good.
Well, thank you all very much. I think that brings us to the end. I just want to congratulate the speakers again. Encouraging this kind of research is a vital mission of ELSO, and just to see what such wonderful projects come out of it is really rewarding. So thank you all, and encourage anyone who has residual questions to come up and speak with the speakers at the end. Thank you.